Hi, Anshita.
This video podcast is for all patients diagnosed with multiple myeloma and the caregivers. I'm Anshita Pandey on behalf of Cancer Rounds. Welcome you all to our video podcast of stem cell transplant in multiple myeloma. Let us briefly learn about Cancer Rounds to start with. In India, Cancer Rounds is the first comprehensive virtual care cancer group focused on providing services to cancer patients and caregivers. The service verticals include diagnostic workup, tumor board opinion, hospital admissions, second opinion, and post-treatment care. Cancer Rounds is born in world of oncology for worldwide cancer patients and survivors. As in verticals, it also includes oncology counseling by a social worker to patients or relatives, education, awareness campaigns, screening events, financial aid. Cancer Rounds is the bridge between cancer patients of significant percentage as medical tourists as well who come to India. Cancer Rounds, being first virtual hospital, is partnered with best oncologists that are making it easier for cancer patients to consult and enroll for remote monitoring, again, which is a boon in the era of COVID as well. We are pleased to invite Dr. Rahul Bhargava, Principal Director, Hemato-Oncology, Fortis Hospital, Noida. Dr. Rahul Bhargava started his journey of stem cell transplant in the year 2010. He has completed over 1,000 transplants till date. Dr. Bhargava has been credited of establishing 10 low-cost centers across India with the vision of anemia-free and thalassemia-free India. Dr. Rahul Bhargava actively collaborates with various government initiatives in order to provide low-cost PMT treatment to the masses. His long-standing vision of the first integrated center of excellence in hematology, pediatric hematology, and stem cell transplant has been fulfilled at Fortis Memorial Research Institute. In 2016, Dr. Rahul Bhargava became the first Indian doctor to do and popularize stem cell transplant in multiple sclerosis. Owing to his vast experience in his field, Dr. Bhargava is considered as one of the best stem cell transplant experts in Delhi and Gurugram. Owing to his keen interest in community hematology, Dr. Bhargava screened over 500 children in schools across India and surrounding areas in 2018. Dr. Rahul Bhargava has also completed over 1,000 CME till date. Due to his active involvement with the community in building awareness around various blood disorders, he is considered as one of the best hematologists in Delhi and Gurugram. So now we can start with the questions and answers round. So we have some FAQs over here. So sir, the first question for you is, what is multiple myeloma and what are plasma cells?
At the onset, I would like to thank Cancer Rounds for giving me this opportunity. And they're doing a wonderful job for bridging up the gap between the rural and the tertiary care hospital sitting in a town A. And tomorrow is a World Cancer Day on 4th of February. And on this day, it's a very opportune moment to discuss about cancers, which are making a stride and people are living longer. But still, that thing has not swept into the country because of misinformation, myths, and lack of knowledge is hurting the delivery of the state-of-the-art cancer treatments to these people across the country and in tier 2 and tier 3 and tier 4 cities. So when we have asked what is plasma cells, so let's understand we have got red blood cells, white blood cells, and platelets. White blood cells has got a component of neutrophil lymphocytes, and lymphocytes goes on to have a plasma cells in the differentiation. And the plasma cells are the memory cells, which tends to produce your antibodies, immunity, and so on and so forth. And as we know in corona era, everybody knows about immunity. So plasma cells are the custodians of immunity cells, which is immunoglobulin. And one fine day, these plasma cells, hundreds are produced, hundreds they die, and suddenly they are started producing in 200, 300, 400, and only 100 dies. And that's where these plasma cells get accumulated in the bone marrow, which is a rigid space between your long bones. So you have got a spine, you have got long bones where there's a rigid space. In this place, there is a red blood cells, white blood cells, and all these three compete in a proportion so as to remain in homeostasis, and that's where the plasma cells increase and disturbs this, thus producing the cancer called multiple myeloma. So multiple myeloma is basically a blood cancer, but not a blood cancer. Because friends, when you hear this podcast, please remember the fact that multiple myeloma does not hold any of the stigmatas of cancer, like hair fall, like expensive medication, like making your life dull, or it's a death, blood cancer being a death sentence. People are living longer. Couple of years back, there were 3 years, 4 years. Now this has expectancy has increased to 5, 6 years and 10 years beyond. And with every passing year, there's a new drug which comes out, which promises the hope. And we are ushering into ourselves from a conventional therapies to a bone marrow transplant to CAR T cells. So it's not a cancer. Believe me, first of all, believe me, this is not a cancer. And these are the plasma cells which can grow into the bone marrow, they can get converted into the blood, they can go to the various extramedullary regions. And when they go into the blood, this is called plasma cell leukemia. So this is what, in a nutshell, is multiple myeloma is. And you remember that once the myeloma cells grow, what will happen? The red blood cells will come down. So you'll have anemia. That's a weakness. The certain kind signs could be anemia. So any elderly person above 50 years of age feeling extremely fatigued and weak and your hemoglobin being low, please go and contact your doctor, because the hemoglobin could be low and this could be the first sign of myeloma. Second, it can lead to the eating of your bones and releasing the calcium in the body. So what is happening is plasma cell is accumulating, and like a termite, it is eating your bone from inside. So it makes your bones hollow. When it makes your bones hollow, what will happen? Bones can break. So what you go with? Back pain. So everybody, all your orthopedics things, and we are going to launch this campaign with Cancer Rounds talking about back pain as a single marker for orthopedicians that this could be a sign of multiple myeloma. So bones become weak, and what will happen? The calcium will increase. The calcium from the bones will go to the kidney and can clog the kidney. So what people can present to you is anemia, low hemoglobin, back pain, which is leading to a bone pain. Third, increased calcium, which can lead to lethargy, weakness, fatigue, and constipation. And the fourth and major important thing is, remember, that is renal dysfunction or renal shutdown. My dear friends, if you have got any of these things, please evaluate yourself. Above 50 years of age, please evaluate yourself for multiple myeloma, because it's still less than 50, it is less common, but above 50 years, it is becoming very, very common in our country. It is not like US, where the 6th or 7th decade, we tend to see multiple myeloma at 5th decade. So please remember these cardinal 4 features, and you can pick up multiple myeloma early.
Thank you, sir, for your answer. As you have also told us about signs and symptoms of multiple myeloma. So next question is, how is multiple myeloma diagnosed? So please.
So first of all, Anshita, we have to imagine, we have to suspect, we need to suspect that. We need to think about it, okay? Once as a differential diagnosis when we go to the hospital. So when you have got all these 4 symptoms, you have a back pain which has got a broken bones, don't wait for the bones to break. So go before that. If you have a back pain, anemia, and high ESR myeloma, think about it. So every doctor, and I think the Cancer Round should promote this and send it to the doctors and orthopedics, because the more important thing to remember is the back pain, high ESR, anemia, renal dysfunction, high calcium. These are the signs where you can pick it up, and their mottling appearance on the bone, which can see as the bones being eaten up by a moth. So first is the differential diagnosis to be kept in the mind. Second is the blood test, which is a complete blood count, which needs to be seen, which is called CBC test. CBC, after that CBCT, what will see? Low hemoglobin. Then you have to do a liver function test. Liver function test is AG reversal. Albumin globulin can be reversed. Fourth thing is calcium. Then what do you see onto that? After that, after calcium being seen, you see creatinine, renal dysfunction. After a renal dysfunction, you proceed ahead to specialized tests called serum protein electrophoresis, serum immunofixation, and serum free titration. We need to investigate. And the diagnostic feature is by doing a bone marrow aspiration and biopsy. And once you do a bone marrow aspiration and biopsy, you send a FISH test and look at the plasma cells. And by FISH test, those like 3,500 to 5,000 rupees, it is important because my nose is different than Anshita's nose, and Anshita's nose is different than your nose, which makes us good, bad, or ugly in terms. The disease will also be good, bad, ugly because of the genetics. When we say genetics, genetics does not mean that you have inherited from your mother, father, or people get scared that this has come from the family. No, genetics means what are the problems which has happened during our existence. We have taken a hit, and that has led to disease process which could be good or bad. So genetics decide that. It is not Rahul Bhargava or any other hospital decide whether your disease is good, bad, or ugly. It is your genetics which decides, dear friends, which is good, bad, or ugly. So it is very, very imperative to do CBC, LFT, RFT, immunofixation, serum free light chains, serum protein electrophoresis, 24-hour urine protein, bone marrow aspiration biopsy, and cytogenetics along with that. Cytogenetics, remember that. And the most important thing after that remains the PET scan. The PET scan has to be done to see whether there's any extramedullary disease there or not. So these are the ways, once you reach to a point, you diagnose these patients with multiple myeloma.
Okay, sir. So, sir, the next question for you is, what are the popular treatments for multiple myeloma? And please give us brief insight to its prognosis.
The second question is easier to answer. Prognosis is ever increasing. When we say prognosis, are you going to live for 3 years? No, you're going to live 5 to 6 years plus. And if everything goes well, 10-year plus has got nothing, nowhere. And when I say 10-year plus, and I'm very confident that within 10 years, you'll have something or the other by 2026 which can cure you. In multiple myeloma, the dictat is we control disease but does not cure you. But as you go on to 2026, I need to make you see the sunlight and the sunrise of 2026, so that in that era, the newer medications are much more affordable, and the older medications which have promised moon can also become more accessible and much more cheaper. So average lifespan has increased to 6 to 7 years. So nothing to worry about it, my friends. Every year we get a new medication. And when it comes to treatment, so very conveniently, treatment started with melphalan, which was year back in 1980s. Then come the VAD therapy, which was a continuous infusion therapy, where the opportunity was written in 2002. When thalidomide came by 2005, thalidomide, which was a prescribing drug for insomniac pregnant females, banned out because of the phacomelia, which happened because of its teratogenicity of anti-angiogenesis. And thalidomide ushered us into a new era. Then came a lenalidomide oral therapy, and then comes the bortezomib, the game changer for multiple myeloma. The response rates from 30% jumped to 70, 80%. And that's how we moved on to the next level. So then comes the doublet requirement, bortezomib plus dexamethasone. Then comes lenalidomide, dexamethasone. And then 2008, 2009, the triplets became the common thing, which was bortezomib, lenalidomide, dexamethasone, bortezomib, thalidomide, dexamethasone. And this is how the combination became more powerful, and which persisted till 2016, 17, 18, where the trial started in 18, 19, started coming up with a 4-drug combination, what's called daratumumab, which is anti-CD38 molecule and used as a first targeted agent in multiple myeloma. So this is how the treatment has moved. And now today's world, majority of treatment is based on how your genetics looks like. Is it good, bad, or ugly? If it is good, you can give it 3-drug combination, which is bortezomib, lenalidomide, and dexamethasone. 3-drug combination. Remember, friends, no VCD, no VTD, only VRD. Remember, in our stated, its thing is VRD, bortezomib, lenalidomide, and dexamethasone. Give 16 such injections. Do an autologous bone marrow transplant followed by maintenance. And now what new things have come up is daratumumab. What new things have come up is MRD negativity, minimal residual disease or measurable residual disease. Because a couple of years back, we were only talking in response of complete responses, then stringent responses, and now we are talking about MRD. It means how much cell kill I have. And if I leave only 1 cell versus 1,000 cells, the relapses are going to be entirely different, and it's going to be a long-term problem. So I think what is more important for the public to understand is simple as that. 3-drug combination, every week bortezomib injection is given up to 16 weeks, followed by autologous transplant, where you take out your stem cells, give high-dose melphalan therapy, and put it back. And what do we want to achieve? What are we trying to achieve by doing this? We are trying to achieve a MRD negativity, means the cell kill up to the level of 0.01%. And that's what we want. And that's why we are doing all this. So today's response rates has jumped up to 19 to 95%, which was minimal at 30% or 35% by in 2000. And in these times, things have really changed on to the next level of moving to the next complicated, non-complicated drugs. And majority of time, Ashita, what is the beauty of this thing is, these are subcutaneous injections. These are not chemotherapy types. When you are afraid, oh, I'm going to get nausea, I'm going to get hair fall. No, friends, nothing such things happens. It's plain simple injection which can be given at home. You need not come to the hospital. And that's what I've been talking to people on Twitter is that for bortezomib, you don't need to come to the hospital. Please give it at home. And that's simple. So bortezomib, lenalidomide, and dexamethasone is the one which we are giving right now. Adding daratumumab, it is expensive. Daratumumab comes at around 1.8 lakh rupees a week. People who can afford, we should give it. It leads to a better MRD result because it helps in cell killing. And followed by auto, as we have spoken about. Auto is a different ballgame. We need to do it. Today also we got a consultation from Patna talking about whether we should do autologous transplant or not. The answer to that is autologous transplant is mandatory. Till the time new medication comes in, please don't fall for things that transplant is the last thing. No. Transplant needs to be done today. Because if the medication gives you a 30 months progression-free survival, means if it tells you, it helps you to reach on to a level where 30 months you will be without the disease, the bone marrow transplant make it 50 to 55, which is almost 1.5 times of what we are having. So bone marrow transplant is mandatory. And that is how we are going to live for 10 years. And in 10 years, that is 2032, we are going to have a cure, a magical thing, what is called as cure in multiple myeloma.
Thank you so much, sir, for such a knowledgeable answer. So, sir, the next question for you is, can multiple myeloma be cured with stem cell transplant, or it's just a conventional treatment pillar?
So, if I have to answer, nothing can cure multiple myeloma right now. So it is going to control, longer time control, not allowing you to spend second line therapy, which is expensive, which is less effective and more expensive. So it helps you to prevent the relapses for a long term. And again, I'm saying it helps you in prolongation of your life without relapsing, because once you relapse, the drugs are expensive. The drugs are not cheap. The drugs are not accessible. And they're less effective. So first chance is the best chance. So autologous transplant is not a surgery. It is taken from the blood from here. You take out the blood, keep it in the fridge, give a high dose melphalan, put it inside. And after 10 days, you go back home. So there will be a hair fall, there will be a mucositis, there will be fever. But how much does it cost in a private hospital like us? 5 to 6 lakh rupees. Though still expensive by any standards, but it is not that expensive as people tell you in tier 1 cities. 15 lakhs, 20 lakhs. No, my friends, 5 to 6 lakhs. Until unless you have an infection or you fall sick or something like that. But this is how we should do it. This is how we should always try to do a bone marrow transplant. It is safe, less than 1% of mortality, not very expensive. You can still take the funding from the government, but please, my friends, please take bone marrow transplant and do bone marrow transplants and go to a center where it does a bone marrow transplant, because that is how we are going to save lives. That's how we are going to have numerous Diwalis and Holis together. This is how we are going to survive till the time we get a new cure for it.
Okay, sir. So the next question which we have is, what happens after multiple myeloma stem cell transplant?
Multiple myeloma goes down, deep down under a pit. It takes time to grow. And in the meantime, new drug comes in. During a transplant, you stay in the hospital for 14 days. 10 days in the hospital, 5 days outside. Once you give the stem cells, it takes time to grow. It's like farming. It takes time, 10 days to grow to a process where red blood cells, white blood cells, platelets are being formed. So I think it's very, very important for all of us to understand that transplant in this country is ever growing. US does 8,000 transplants in multiple myeloma, and we do only 500 to 600 transplants. It is not that we don't want to do it. It is not that we don't have an infrastructure. It is not because also that people are afraid. It is a general myth that the bone marrow transplant is the last thing at the last stage. No, it is the first thing in multiple myeloma, and we need to do it as soon as possible.
Next question is, how many times can a patient have a stem cell transplant for multiple myeloma, and what is tandem transplant, sir?
Very nice question. So multiple myeloma, as we know, that they will relapse. Once they relapse after 5-6 years, they can undergo a second transplant based on their genetics, good, bad, ugly, what it is. So tandem transplant is once you do a first transplant and you have not achieved the MRD negativity or a stringent CR, you do a transplant after 3 months, which is called a tandem transplant. It's like a tandem bullet, one after the another. Why? Because you want to kill the bad cells to the last. It is being used in a high-risk groups like 17p, which is a genetic abnormality. So based on your genetic abnormality of multiple myeloma, you tend to do a tandem transplant like 414, 1q, 17p. This is where you do a tandem transplant. What kind of other transplants you can do? Allergenic transplants you can do. Why? Because we know it's not curable, and we have got still a substantial number of patients who develops multiple myeloma at the age of 30 to 40. And if they have to survive till the natural age, 75, you need to do an allogenic transplant, which can be a curative in 30-40% people. So allogenic transplant is another one which can be utilized at that moment of time. So these are the ways a transplant needs to be done. Second important point is any person who gets a response for more than 2 years with a transplant can get a second transplant also done. And that's the most important thing to understand.
Okay. Sir, the next question is, what to prefer, allogenic stem cell transplant or autologous stem cell transplant in multiple myeloma cases?
So it is very clear. The first transplant which needs to be done is auto. And that is why I'm repeating that up to 6 lakh rupees, you can get a transplant done easily. It is not an emergent condition. It is an elective procedure. You can collect money. So every multiple myeloma up to 75 years of age should remember that they can get a bone marrow transplant done. It's very, very important. Age is not a barrier, friends. Will is a barrier. Knowledge is a barrier. So up to 75 years of age, every single patient should undergo an autologous transplant. Allogenic transplant is reserved for those people who relapse after auto and they are younger, who can tolerate the treatment. So this is where we stand in terms of auto and allo, and majority of places in India do auto. Exactly few centers which do allo at this present moment of time.
Okay, sir. So the last question for today's podcast which we have for you is, what need to be monitored after autologous stem cell transplant in multiple myeloma?
So we need to understand that blood tests will be done lifelong till you are alive. Every month you will get a maintenance dose called lenalidomide. Oral medication needs to be taken. CBC and myeloma profile, which consists of serum protein electrophoresis and serum free light chains, needs to be monitored every 3 months till disease progression. So multiple myeloma in 2 decades have made a huge strides. From a 2-year survival, it has progressed to 7 to 8 year survival. Drugs have become much more sophisticated and smarter. It does not lead to more of a toxicity. Toxicity is entirely different from low hair loss, nausea, vomiting, abdominal pain, skin becoming dark. It has reached to a point which is more targetable in terms of peripheral neuropathy or low platelets. Similarly, the transplant has become more accessible and less expensive, more people's friendly, thus leading to the greatest stride in expectation of life, expected life expectancy in multiple myeloma patients. So we are happy to be in this era. It is not so good to have a cancer, but it is still better to have multiple myeloma. With a good cytogenetics, we can save you drugs can prolong your life, hoping that in 2026, we might have a cure for multiple myeloma.
Thanks, Rahul, Dr. Rahul, for your valuable inputs that is need of the hour to all of our followers, specifically the patients diagnosed with multiple myeloma and caregivers. We request all our followers to contact us on website link displayed on screen for queries. All your queries related to multiple myeloma and innovations in treatment related to stem cell transplant will be directly answered by the esteemed and eminent international Hematologist Dr. Rahul Bhargava. We'll soon come with new informative video podcast. For more information, stay tuned and subscribe our channel. Thank you so much. Thank you, sir. Thank you so much for a valuable time. Thank you, sir.
Thank you.